Well, good afternoon, everyone. Thank you so much for joining us. Welcome to our MedTech Unplugged webinar series presented by Navro, where we feature world-renowned physician and industry experts sharing their insights across various sectors of the MedTech industry. Special thank you to those who joined us for last month's webinar on pacemaker technology, and welcome to everyone new. Our series has two objectives. First, to expand your understanding of the dynamic world of medtech, helping you explore and identify areas of interest. And second, to equip you with valuable knowledge that will prepare you for interviews as you transition into the workforce. It's my pleasure to introduce our esteemed speaker for today's webinar, Dr. Amir Schricker. Dr. Schricker is a leader in the field of cardiac ablation with an extensive background in both clinical and research settings. He is a cardiac electrophysiologist and the medical director of the cardiac electrophysiology at Sutter Health, Palo Alto Medical Foundation, and the University of Southern California. Dr. Schricker's work focuses on the intersection of engineering, medicine, and technology, where he has been at the forefront of innovations that have shaped the field of cardiac ablation as it is known today. Dr. Schricker will guide us through the evolution of cardiac ablation in the treatment of cardiac arrhythmias. He'll discuss the engineering advancements that have made this technology one of the most effective treatments for debilitating cardiac conditions. And for students and faculty in engineering and health sciences interested in medtech, Dr. Schricker's presentation will provide insight into the collaboration between the medtech sector and practicing physicians in advancing patient care outcomes. Without further ado, please join me in welcoming Dr. Schricker.
Thanks so much. Thanks, Jenny, so much for that kind and flattering introduction. I want to thank Navro as well for inviting me to this. I'm flattered to be here, and I'm excited to the next hour or so to talk to you guys about what I do, the roles of technology and engineering in what I do, the field of what I do, and then hopefully field some questions from you guys. Let me go ahead and share my screen. All right, do you guys see my slide?
Yes.
Great, very good. So I call this catheter ablation for cardiac arrhythmias. Arrhythmias are abnormal heart rhythms. So catheter ablation is what we're going to be focusing on today. Here's a brief overview of my talk. It'll be capped pretty much at 30 minutes, but I did want to provide sort of a roadmap of where I'm going. First, I'm going to talk about what is cardiac electrophysiology, which is my field. I'm going to give you a background on the basics of arrhythmias. The reason I'm going to go into a little bit of background here is that I could jump right into showing you pretty pictures and cool technology, but it really wouldn't be as impactful and as you may not appreciate as much if you didn't understand sort of why we're doing this in the first place. So I'll give you a little very brief crash course into EKGs. We'll jump into mapping and ablation, which is where the cool technology is. And then very briefly talk about the role or potential roles for engineering and engineers in my field. So let's just jump into what is electrophysiology. Let me first start, though, with sort of where I come from. It's actually very similar to what I'm assuming is most of you guys. My background actually is in engineering myself. I went to college at Berkeley and majored in electrical engineering and computer sciences, the ultimate of geekery, but I loved it. I knew back then I was interested in medicine, or at least the biomedical field. And I also love math and sciences. I didn't quite know where to go with that. I knew I could do engineering first and then do medical school or the medical field later on. You can't exactly do it in the reverse direction. So that's why I jumped into this field. Kept me very busy. I knew I wouldn't say I knew, but I had a hunch I wanted to go into medicine. Because of my rigorous coursework, though, I couldn't take the MCAT in time to go straight from college into med school. So I had a gap year. And during that year, actually, I was doing imaging research. And this is actually where things really started to sort of hone in my mind in terms of what I wanted to do for my future. I focused on imaging, specifically signal processing and image processing during my EECS career in college. So for my 1 year of research, I was at UC San Francisco where I was in the Department of Biomedical Engineering and Radiology doing MRI research. And it was a fantastic application of my signal processing background. it was actually during that year that I decided not to apply to medical school just yet because I was so fascinated by the application of medicine, sorry, the application of engineering and all the skills that I had to the field of medicine that I wanted to pursue it a little bit further. So I went to grad school. I went to Johns Hopkins and for biomedical engineering and got a master's there, which further, essentially with laser focus, got me, narrowed down in terms of the field I wanted. I went out there for the imaging, an imaging project, ended up being a cardiac imaging project. So even though I went there for the imaging, I ended up falling in love with the cardiac side of things, and where I was introduced to this field of electrophysiology also. So I was introduced to cardiology and EP sort of simultaneously. And it's from there where, as they say, the rest is history. I went on to USC and got my medical degree, knowing I wanted to do EP from the very start. I was a little unusual, but so be it. I knew what I wanted to do, and I stuck with it. Suffered through many, many years of medical training, 8 years specifically after medical school, and now here I am. And where is that? It's electrophysiology, the field also known as EP. We're the branch of medicine, specifically of cardiology, but the branch of medicine that focuses on the electrical activity of the heart. The heart has many aspects to it. It's like a house. There's the plumbing, there's the electrical wiring, there's the structure, like the walls. Just like that, the heart has the same as well. There's the plumbing, which is the arteries of the heart. When you have problems with those, you get things like heart attacks. There's the actual structure of the heart, which is the walls and the myocardium and the muscle, the actual squeezing function. And then, of course, there's the electrical activity of the heart, which is the heart rhythm. That's all electricity. So essentially, I'm the electrician of the heart, and I love it. It's the perfect intersection of my background in the field of medicine. We diagnose and treat heart rhythms using a variety of techniques. So we can use medications, of course. These anti-arrhythmic medicines, as they're known, requires a sort of an intimate knowledge of the cardiac action potential, which many of you may have, some exposure to. I'm not going to focus on that for this talk, at least. There's implantable devices. I'm talking about things like pacemakers and defibrillators. I think a few episodes or a few sessions ago, Dr. Ricky Green gave you a comprehensive overview on implantable devices. So again, I won't be talking on that. What I will be focusing on is this, though, catheter ablation, using catheters, long skinny tubes, to do all sorts of marvelous things within the heart, minimally invasively. So let's dive into now the basics of arrhythmias. Arrhythmia simply means an abnormal heart rhythm. There's a normal heart rhythm, which is, as you see depicted in front of you. This is a little cartoon I always use for the heart. It's as if you're looking at a person right in front of you. So on our right is the person's left. On our left is the person's right. This star, what you see in red and what you're going to see here and in the next couple slides, keep an eye on the red. This is normal. Try to imprint this in your mind for the time being. Each and every heartbeat starts with an impulse here. This is called the sinus node. And it starts at the top chamber in the atrium and works its way down to the bottom chambers, the ventricle, to cause one normal heartbeat. The heartbeat does this automatically, rhythmically, every second of the day for the entirety of your lifetime. And it creates this EKG. This is just a depiction of the electrical activity of the heart as specific waves called the PQRST. Again, we won't go into the details of that, but this is one normal heartbeat. My entire career, my entire field is dedicated to getting people to achieve this again, because there's a lot of rhythms that don't look like this. Here's a few examples. On one end of things are the slow heart rhythms. So in green, you see the normal EKG. Down below it, you see some examples of slower heart rhythms. So here's one. There's just a simple slow heart rhythm called sinus bradycardia. The heart rhythm is a little slower than it should be. It can be mildly bothersome. It could also be catastrophic. It could be as extreme as having no heartbeat. Or you could have some skipped heartbeats. Again, this is just a brief overview, but these are slow heart rhythms. These are dealt with and treated by those cardiac devices like pacemakers. On the other end of the spectrum, we have the fast heart rhythms. These are the ones that are potentially life-threatening. In the upper left here, we have a whole category of heart rhythms called SVT, supraventricular tachycardia. You can see that this is much faster compared to the normal heart rhythm. This is actually quite common in everyone of any age. So many of you in the audience perhaps may have had SVTs. You may have them. I see one of the things I love about my field as opposed to the rest of cardiology, which is just a bunch of old men. There's a lot of young, otherwise healthy patients that I see. People your guys' age. I have several high school students, many college age students. A lot of young adults that have SVTs, they just have one little bit of extra electrical wiring in their heart that causes this, but otherwise they're completely healthy, and this can be treated and cured. There's SVTs. There's atrial fibrillation. You guys may already know about this because it's very common. This is a disease more of the older age, but this is an irregular heartbeat. We get to the bottom ones, ventricular tachycardia, ventricular fibrillation. These ones are life-threatening. The one on the left, you see, this is sort of on the road to death. The one on the bottom right is death. When you hear about people getting cardiac arrest, it's almost always one of these two abnormal heart rhythms. Here, you clearly see the most extreme circumstance where there is no organized electrical activity. Quite different than this. And then taking a step under, looking beneath the hood a little bit more, how do these happen? Well, mechanism is of utmost importance here. I'm not going to go into too much detail here, so don't worry, there's not going to be another school lecture, but it's crucial here for you to understand the basics of this so you can sort of appreciate why we do ablation, which I'll get to in a few slides. Any abnormal heart rhythm is due to either an abnormal focus, which means one site in the heart, not that star that I showed you in that right atrium, but some other site in the heart, somewhere else, is just firing off inappropriately and sort of taking over the heartbeat. It sort of usurps power away from that sinus node, and then it drives the show. Or is concept known as reentry, which is essentially a circuit within the heart, some short circuit, as I tell my patients. There's a short circuit in there. Every time it takes one spin around, it sets off one heartbeat, and these tend to go very fast. So keep this in mind, an abnormal focus in reentry. This is crucial to understanding why mapping and ablation does what it does. So a few just examples of these. An atrial tachycardia is an abnormal focus. We have some other site here. Remember, normal, we have the impulse originating in the top right chamber of the sinus node. Here, I drew it here in the left atrium. This is an abnormal focus. On the EKG, it shows like this. Each of these stars is that little focus firing off inappropriately. Here's another one. This is a very common SVT. Again, this is the one that even young people can get. Here, it's actually a little circuit within the heart. The little bit of tissue that connects the upper chamber, the atria, to the bottom chamber normally should be just one little conduit, one little path of a couple cells that's just a pipeline connecting the top chamber to the bottom chamber. In about 20% of people, they have two of them. We call that dual AV nodal physiology. So when all the circumstances in the body are right, these two can set up a little circuit. Here's a little short circuit right here, spins round and round and round. Each time it spins around and fires off a heartbeat. This goes very fast and can show up as pounding heartbeats or even people fainting because the heartbeat is going too fast. Here's another one. This is more of a macro reentry. The other one was micro because it was tiny. Here's a macro reentry. This is a condition called WPW. Some of you may have this too. This can run in families. This is a fairly common condition. Here, there's another little extra bit of tissue in the heart somewhere other than that main one that I was telling you that connects the top chamber to the bottom chamber, the atrium to the ventricle. And again, if all the settings and all the circumstances in the body are right, and you set off that circuit, the electrical activity goes from the top chamber down the normal node, down to the bottom chamber, and it comes right back up again through that accessory pathway, that WPW, that little bit of extra tissue, back up to the atrium again, and then you're off to the races, spinning round and round and round. All right. That was just a brief, very brief crash course into arrhythmias. Let's keep that in mind now and see exactly how we can treat these. So again, we're not using medicines here. We're not using devices. We're using mapping and ablation. So what's our goal here with ablation? How can we use this technology I'm about to show you? Ablation just means zapping away. We're just cauterizing part of the heart. How can we use that to actually fix people? Well, remember, here are those same two mechanisms I just showed you. We have an abnormal focus here, something just firing off, and we have reentry here, which is a short circuit. If you want to get rid of an arrhythmia that has an abnormal focus, you need to obliterate that focus. And when we could do that again with medicines, but when it comes to ablation, we can actually use our tools, our ablation catheters, to go put our ablation tip here in the heart and just zap it away. We turn on a little bit of heat energy, a little bit of RF, radio frequency, and we just zap that area away. We get rid of it, create a little bit of scar tissue, and that area is gone, typically for good. Usually we do consider this a cure. So to get rid of the abnormal focus, you just zap away the focus. What about reentry? This is a little trickier, but a lot more interesting. Here, to get rid of this short circuit, you don't need to obliterate everything in the circuit because sometimes this involves the entire heart. You don't want to ablate the entire heart. So what do you do here? you just simply interrupt that circuit. Again, we can do this with medicines, but it's much more effective and potentially curative when we do this with ablation. So here we find the right spot in the heart, and we find that right spot with something called mapping. And I'll tell you about that in a moment. We find the right spot, and then we interrupt that circuit with our ablation. Using that same heat energy or any other sort of energy, we'll talk about that in a moment. We interrupt that circuit, eliminate that one key critical component of the circuit, and then your circuit no longer exists. You've broken it. Just like the basic light bulb circuit you guys may have done in your, honestly, probably in grade school, not even in college level. But you have a light bulb. You have a light bulb connected to a battery. If you want to turn the light bulb off, what do? You don't need to blow up the entire circuit. You don't need to obliterate the battery and the light bulb. If you have a switch in here, you just simply flick the switch, interrupt the circuit, and your light bulb turns off. Exact same thing here with ablation. We're interrupting the circuit to achieve this. So before you can ablate, you need a map. Where do we ablate? Well, this is where mapping comes into play. Mapping is evaluating the heart. We're querying every single spot in the heart, every single spot of relevance. And we usually have some idea based on the EKGs and other things, roughly where in the heart to go to. And then mapping is using your catheters precisely to go millimeter by millimeter to figure out where that abnormality is. All right? So the EKG gives us sort of maybe the state where the, if we're looking on the map, where the state of where this abnormality is. The mapping tells us the precise street address of where it is. So let's jump into my world, where I walk into every day, or at least a couple times a week. This is known as the Electrophysiology Lab, or the EP Lab. Looks very high-tech and futuristic because it really is. A lot of patients call it, sort of looks like a spaceship or the cockpit of a spaceship. It really is. It's quite high-tech. This is all that goes into doing one of these cases. The patient lies here in front of us. We have an X-ray arm here, the C arm, which allows us to get a real-time X-ray, but specifically video X-ray. We call that fluoroscopy. So video moving X-ray images, so we see where we are inside the heart with our catheters. We have all this fancy technology, ultrasound, our power generators, our signal, our signal processors for our ablation catheters, and then all this screen in front of us, which does the mapping. We see what we're doing in real time as we rove around the heart with our catheters, doing that mapping that I was telling you about. And then with these same screens and the same technology, we actually go ahead and map. There's usually about 6 people or so in the room here, from doctors and nurses and technologists, all helping with this. I'm here at the side of the bed doing my part. This is what it looks like. This is not me. I just found this online, but this is really what it looks like. We're doing this minimally invasively. These are some of the catheters you can see. They're just long, skinny tubes. They're about maybe 2 millimeters in diameter. They come in various thicknesses, but they could be as little as that. They go in through the groin. We go in through either a femoral artery or a vein at the groin. All roads lead to the heart. We put the catheters in, we snake them up into the heart, and that's where we take care of our business. So I'm standing here doing all this stuff just from the groin, manipulating these catheters with my own 2 hands. So what are some of the things I'm doing? Well, this is how it was actually a couple years ago. This is a mapping catheter. It looks pretty boring, and by today's standard, it really is. This one's a quadrupolar catheter, meaning there's 4 poles, 4 electrodes, the distalmost tip to the proximalmost tip, and you measure in bipoles. So this electrode to this electrode, or this one to this one, you measure in bipole pairs, and they create a signal. They look like this. Here's the EKG on top. That's what the heart looks like when you do the EKG that you guys may know about that I showed you earlier. This is what the heart looks like from the inside. This is what we EPs, this is how we view the signals of the heart. Don't worry about what it looks like. Just know that there are signals from inside the heart that we're looking at. This is pretty opaque. This is pretty tough stuff to master and comprehend. But this is, what our training is all about. But back in the day, they could only do point by point. And I wouldn't even say they. I did this back in my training about, 10 years ago. Point by point, we go and, query the heart. We map the heart. It was a very slow, very time-consuming, very boring, laborious process, but it's all we had. Fast forward just a couple of years, not that long ago, really. We have catheters that look like this. They're multipolar catheters, even more than that 4-pole catheter that I showed you. This one that I commonly use is called the grid. There's actually 16 electrodes here, spread across 4 splines, 4 little filaments, 4 on each one, and there's 4 splines for a total of 16. Here's one. This has 5 splines. It's called a pentarray. Each of these has about 5 electrodes on it, and there's a total of 5 splines. So, 4 electrodes across 4 splines. So there's 20 electrodes there too. These are the technology and the tools that we use for high density mapping, for high resolution mapping. And then when you take these signals and color code them, color code their timing, you can create some nice images like this. These are sort of the electroanatomic maps, as we call it, electroanatomic. That means we take the electrical signals from inside the heart, the signals that we get, plus the 3D geometry of the heart. So we use magnets and other technologies such as impedance, other electrical parameters, to know precisely where these catheters are inside the heart. So we can create a geometry or a shell to create a 3D digital model of every patient's heart when they come in for one of these procedures. So we know what that patient's heart looks like. We know in general what everyone's heart looks like, but we need a precise replica or a model of that patient's heart. So we create the model, and then using the color coding with the electrical signals. Here are some of those signals I just showed you a few slides ago. When the machine or the mapper, the person sitting behind the computer screen there, which is not me, it's someone else, it's a technologist from one of the mapping companies, the manufacturers, they either annotate this manually, or nowadays there's a lot of automation, but with some human oversight. They annotate these, again, or automate it, and then you create like a timing diagram here, which is color-coded and tells you where to go. You can create some nice, pretty pictures like this. This is the top left chamber of the heart. This is the left atrium viewed from behind. You see color coding here. This color coding, I can tell you, tells us about the timing. It's the colors of the rainbow: red, orange, yellow, green, blue, purple. Red is actually, white is the earliest. Then you dive into the rainbow colors. Purple is the latest. That tells us about timing. You can use these same colors to tell us about voltage. Voltage in the heart tells us about the health of the tissue. Certain colors that represent the high voltage tells you about healthy tissue. Other areas which have a lower amplitude and then is color-coded differently tells us about disease tissue. All of these are sort of the substrate, as we say. They create the background, the necessary conditions for abnormal heart rhythms to take place. Here's just sort of a video of, again, one of the chambers of the heart. So this electroanatomic mapping, you and myself and the mappers, you're sort of these digital cartographers, you're map makers of the heart. You use this very sophisticated technology in real time to create this. This would have taken hours. Sorry about that. This would have taken hours years ago. This now gets done in just a matter of minutes. It's really exciting. It's really fascinating. It used to be a painstaking process, and now not only is it not painstaking, it's actually kind of a joy to do this in real time to see how things go. And the color coding that you're seeing, these sparkles, this is actually called a sparkle map. So if you take the color coding one step further, you can actually put dots where each area is being depolarized, and you can actually see a map of how the electrical activity is propagating throughout the heart. Fascinating stuff. So we've mapped. We know where to go. Now what do we do with that information? Now we have to go after it. We have to actually do something to help eliminate it. That's where ablation comes in. Ablation is done with catheters also. They're different catheters than the ones I just showed you. So typically you map with the catheters I just showed you, and then when you have your answer, you take out one of them and replace it with this mapping catheter. Here's a typical one. This is sort of a funny view, but it's just trying to show you the entire catheter. This is just another long, skinny tube with a handle here. My hand goes here. This is probably about maybe 8 inches long here. So it's just something you grab with your hand. You manipulate in essentially all degrees of freedom. You could turn it clockwise and counterclockwise. You could flex it front and back, left and right. And then the other end of it obviously is inserted into the patient. Simple as it seems, this is quite a complex and sophisticated piece of technology here. This is what it looks like on the inside of the heart when it comes in, from the veins and the arteries. And this is up close what one of the tips of the catheter looks like. They deliver the energy. It could be heat energy, known as radiofrequency ablation. It could be cold energy, known as cryoablation. It could also be known as a very new technology called pulse field ablation, PFA, which is not thermal. It's neither heat nor cold. It's just a little blast of an electric field. These catheters deliver the energy. They can also act as a mapping catheter, so they know they can record, the electrical signals. They're also a mapping catheter in the sense that the mapping system and the magnets know precisely where in the heart this catheter is down to the millimeter with these location sensors. And it can also measure the contact force. So you want to make good contact with the heart tissue if you want to deliver the energy, but you don't want to push so hard that you poke a hole through the heart or burn a hole through the heart. So you have these contact sensors here that tell you how hard you're pressing. It actually quantifies it. So a lot of sophisticated technology that goes into this catheter design. It's the tip of the catheter here that delivers the energy. So here's a really cool example of the ablation of that WPW. This is that little extra bit of tissue that connects the atrium to the ventricle that, again, many people are born with, can run in the family, but can also cause, one of these SVTs. We find this little area of specific, we identify this area, we localize where that specific bit of tissue is, because it could be anywhere inside the heart, anywhere inside the heart. We have some ideas from the EKG and where it is, but we have to use mapping to precisely fine tune where it is, because these little bits of tissue, mind you, are a couple millimeters long. This is very small. So we have to go and fine tune it. And you can't see it very well here, so I apologize, but just take it on faith that this is the patient during the tachycardia. This is them, these signals down here during the abnormal heart rhythm. They're firing away, they're racing away. In this case, about, let me just take a look here. They're racing away here about, 130 beats a minute or so. These are the signals. And then I turn on ablation here. I can tell, I just know it's mapped on the system. And then here within 2 seconds, the arrhythmia has stopped. Again, you can't tell from here, but if you're looking up close, you can see it. So in less than 2 seconds, we've eliminated this little bit of tissue. In 2 seconds, with pinpoint accuracy, we've gotten this little bit of tissue that's caused this patient either to have rapid palpitations that are bothersome, or that may be debilitating, or that could be life-threatening. People that have WPW have a slightly higher risk of sudden death for various reasons related to that. Within a couple of seconds, because of accurate mapping, we've been able to get rid of this permanently. This is deemed a cure. With one ablation technology, one procedure with this technology, there's greater than 95% chance they don't need treatment ever again. So again, we consider this curative. Let me give you a couple more examples. Here's an example of an atrial tachycardia. Remember, this is some abnormal focus other than the sinus node. It sort of usurps power. It takes away power from the sinus node and just starts driving the show by beating very fast. This is a patient I had. This was, they were having this tachycardia during the procedure, which is always what we want to see happening before our eyes so we can study it. And by study, I mean map it. This is the left upper chamber of the heart. Also, this is the left atrium. In white, you can see the site of earliest activation. This is one of the veins that connects to the heart, the pulmonary veins. This is one of the 4 veins that delivers oxygenated blood from the lungs back into the heart. Based on electrical activity, I know this is the earliest here. Again, this is just color-coded, so it's based on legit, real signals. Earliest signal is here, and then it's sort of like a bullseye, like a target, or like ripples emanating from a stone that you throw into a lake. You see, like with of the bullseye, there's red, orange, yellow, green, blue, and purple. So it shows the earliest activation here, and then it emanates out there to the rest of the atrium. With mapping, I was able to pinpoint it right here. I put my ablation catheter there, and then with a couple ablation lesions, it was able to get rid of it permanently. Oh, right there, just shows up there. Here's another one. This is that WPW again. Just a reminder of the circuit. We're going down this normal this normal node of the heart, come down to the ventricle, then, oops, we go back up this little bit of extra tissue called that accessory pathway, goes back up to the atrium, and again, we're off to the races, spinning round and round and round. Here's what it looks like in a still image. This is after a lot of precise mapping. This was that previous image I showed you, but this is just sort of a little bit more clear without so many catheters, just for clarity. You see, this is the ventricle. What I'm showing you here, if you can see my mouse, I'm showing electrical activity from this ventricle here down below into the atrium through that little accessory pathway. So everything is converging upon this little isthmus here, this one little pathway that's millimeters long, and then it erupts into the atrium. So it's as if you have traffic going from 8 lanes of highway down through a single lane tunnel, and then it comes back out again on the other side. Here, everything converges upon this little area and then erupts out into the atrium. And here, same image, or sorry, similar concept, but just a different patient. You can see it actually, if you animate this and use one of these sparkle maps, you can see the electrical activity. The propagation is coming into the ventricle or through the ventricle, funneling into this little accessory pathway, and then boom, erupting out into the atrium. So what you do, again, like you saw a couple slides ago, position your ablation catheter here, turn on the energy, and boom, in real time, it goes away if you've done a good job within just a couple seconds. One last example, this is ventricular tachycardia. This is one of the life-threatening heart rhythms. This one is a really beautiful example. Another way you can animate it is just you color code the wavefront. This is the leading edge of the propagation. This is, again, reentry. This is a figure of 8. You can see it funnels in through this little common isthmus, and then it erupts going above and below. And then it comes back in from both sides and funnels in through this tunnel, this critical isthmus, as we call it. This is phenomenal, what you're seeing in front of you. It may not look like much, but the reason is up until a couple of years ago, we couldn't even map ventricular tachycardia because when we put people into this rhythm, we can induce this. We have a lot of power over the patient's heart. We can induce death. We can bring them back from it and all sorts of stuff in between. We like to induce this because we want to see precisely where in the heart this is coming from. But as you might expect, when you induce this, the patients could potentially die. Their blood pressure tanks. It goes to almost nothing. And you obviously can't keep a patient like that. So we have to quickly resuscitate them. And by that, I mean, give them a defibrillation. We got to shock them right then and there on the table, let them recover for a few minutes, then put them right back in there again, and away you go again. There's only so much a heart can take. So we usually had very limited data when we did ablation for ventricular tachycardia, which is why we had much less success. And we went on a lot of surrogate markers to figure out where we had to go, or we did sort of this carpet bombing, as we called it. We knew there were some areas of the heart that were abnormal. We didn't know which parts of them were relevant for this circuit, but we just ablated all of it. And I'm talking about maybe a third of the heart, a fourth of the heart, half the heart. We just lesion by lesion would zap away, burn away a good chunk of the heart. Sort of, again, casually we call that carpet bombing. Not very elegant, but it's essentially all we had. But now with high resolution mapping and with improved ways to keep people alive during this tachycardia, we have ways to essentially put them on bypass. It's called ECMO. It's a way to have another machine breathe and pump for the patient. Just like you get put on bypass when you undergo open heart surgery, we can similarly do the same thing here. We keep them alive during the tachycardia, and then with the high resolution mapping that I will show you, you get a beautiful circuit like this where you can see precisely where this critical isthmus is here. So again, in that traffic example, if you want to, I don't know, eliminate the cars, you don't go away bombing all the 8 lanes of the highway. You get that one common isthmus, that one tunnel, because everyone has to pass through there. So that's precisely what we do here. With a couple burns, usually we can stop this. Now, in this case, this is not a cure. This is a much more complex arrhythmia. We don't cure it here, but the goal is to minimize how much someone has. But still, a huge win in the field for what we're able to offer the patients nowadays compared to before. Before I move on here, let me just also give you a bit of appreciation for where we are in terms of where we've come. Even before I came along, we're talking about 40 years ago or so, like in the 80s. Everything you saw here, which is done minimally invasively through thin little filaments, thin little catheters through the groin, just to zap one little 2-millimeter bit of tissue. That little bit, that used to be done by open heart surgery. They used to crack patients' chests open, try to get to that one specific spot, and with the help of electrophysiologists, people like me back in the day, people like me would do the mapping. We'd be there. Not me, I'm not that old, but my predecessors, the shoulders, the giants of our field would be there together with the surgeons working side by side, mapping from the outside in the inside of the heart, trying to figure out where to go. Then the surgeon would go there and literally cut that bit of tissue out. They would cut it away. Only up until maybe the mid 80s or the 90s was it done that way. Only recently now have we begun to do this minimally invasively with catheters. So this is a huge advancement in the field. All right, so what's the role for engineers in engineering in EP? Well, I will state that there's really no better field where technology can be applied to the biomedical field than EP. There may be some other ones, like some stuff, maybe like in neurology, we're studying the brain. The brain is electrical signals. Only the brain and the heart are the organs that have electrical signals in the body, but we really don't know much about the brain. So, I don't count that as a huge win. But in cardiology, we've had huge successes. The only other field I might say would be mechanical engineering with things like orthopedic surgery, because there it's very mechanical based. But again, there's no field that depends so much, that is so intimately related to technology as cardiology and specifically EP. This is the perfect marriage of the two. So what are some roles for engineers? Well, obviously, one is to do what I did, go into the medical field and be a physician. But what if you don't? There's a lot of exciting opportunities. When it comes to mapping and ablation, which is what I'll focus on as opposed to the device implants like Dr. Green talked about a couple months ago with the cardioverters and the defibrillators and the pacemakers. When it comes to what I've been talking about, well, every step of the way, there's technology involved. Every step of the way, there's a need for engineers. So catheter design, how to get those catheters smaller, lower profile, more flexible, how to get them more information to be gleaned from the tips, the contact force, the temperature to make sure you don't overheat, its location in 3D space, things like that. Ablation energy. For those of you interested in biophysics, this is huge. Like I said, we have traditionally for decades had two different forms of energy. They're thermal based. One is heat, one is cold. You can either freeze the tissue, you can heat it up with radio frequency ablation, radio frequency energy. But now we have a brand new form of technology called pulse field ablation. It's not thermal. It's a little blast of an electric field that's very efficient because it's very selective for cardiac cells. It doesn't affect any of the structures that are close to the heart. One of the big potential risks when you do ablation inside the heart is because the heart's is close to other parts of the body, like the esophagus or the nerves that activate your diaphragm, the phrenic nerve, or other things, you can burn or affect those other structures. With PFA, with pulse field ablation, this is not the right term, but let's just say the resonant frequency, if you will, of that energy is only selective to cardiac tissue. So you really can't. It's theoretically impossible to damage other tissue, which is a huge win and a huge success story when it comes to ablation. Electroanatomic mapping software, those of you into software design and image processing and signal processing and 3D rendering. I mean, you saw some of those images I showed you. They may not mean a whole lot to you without knowledge of anatomy, but that's amazing what we can do in real time right there in minutes to recreate the patient's heart. Clinical specialists. This is a great way if you want to sort of have one foot in technology and one foot in either business or something that's a little bit more patient facing. These are people that work for the manufacturers that come in and actually are there for each and every case with me. They're sitting there behind the computer doing the very sophisticated management of the catheters. They're looking on the back end, sitting there behind the screen, looking at each of these signals. Yes, they have to know the technology. They have to know the software, but beyond that, they need to sort of know what this technology represents, what those signals represents. They're not there just as sort of as an IT person. They're there to know what these signals represents and whether it's annotated at the right spot. And knowing that requires some knowledge of, or more than some knowledge of anatomy, of physiology, of electrophysiology. And then there's consultants, of course. You can work for any of the well-known or not even well-known consultant companies and work for some of these, consult for a hospital or technology companies. So there's a lot of roles for engineering in med tech. There's a lot of roles for engineers in the field of technology and just biomed and all of, in general. So you guys have picked a great field. I can say that from firsthand experience that really there's no better field nowadays to have gone into. Your future really in terms of what you want to do is wide open. So congrats on picking it. Hopefully you see it through. I'm happy to answer any questions, but for now, here's my email address. I'm more than happy if you guys want to reach out after the fact as you sort of get some questions to answer anything specific about this talk, about the field, about career advice, things like that. So with that said, I'll hand over the mic. I'll stop sharing and hand over the floor back to you, Jenny.
Dr. Schricker, thank you so much for that exciting and informative presentation on cardiac ablation. It was really amazing. We'll open it up now for some questions. So all of your lines are muted. If you have a question, please unmute your line. You're also more than welcome to put it in the chat and I can go ahead and make sure we present your questions that you pose in the chat. I'm going to kick it off with the first question. Dr. Schricker, where do you see this exciting therapy and technology moving forward in the future?
Great question. That's always the question. Everything in the field of medicine and everything, technology-wise, everything is going for smaller, less invasive, faster, things like that. So where this is going is, at least with the ablation technology, because mapping will always need, and that will probably have to be done for the most part invasively. but somewhere that this field is going, maybe the ablation component of it. And that may very well in the future become non-invasive. We already have this technology available for select cases, very sort of extreme examples for those dangerous heart rhythms, like the ventricular tachycardia. For patients that either have failed catheter ablation or are unable to go it, whether they're too sick, they're like too critically ill, or there's a part of the heart that we just simply can't access with catheters, and there are certainly some of those. We can use radiation. We can use a stereotactic radiation. So this is the same scanner. Or actually, that's not the right word. Sorry. This is the same linear accelerator that the oncologists and radiation oncologists use to target sort of with gamma knife, for example, with like pinpoint precision tumors. The patient gets in this linear accelerator, looks like a big fancy CAT scan, and then with pinpoint precision is able to send the electrons or the neutrons in and non-invasively kill these tumor cells. We're nowadays starting to use that to do it for cardiac ablations too. So that's very hot technology. This is hot off the press. We're doing this ourselves here. This is something that very few places are offering, but it's starting to become a thing. So doing ablation non-invasively is something. Until we get there more routinely, another avenue for ablation is doing it sort of robotically. There's some catheters that just go in and are manipulated with magnets. This has been around for a while, had limited success a decade or two ago, but there may be a resurgence of it with everything sort of being done robotically. So again, smaller, quicker, safer. That's always the goal with technology and in medicine. But those are sort of precise, specifically where it might go with mapping and ablation. And then the other big area, sorry, I forgot to mention, was the mapping part. I misspoke. It's not necessarily true that it needs to be done invasively. We can do a lot of this non-invasively too. There's a lot of surface EKG mapping that's being done nowadays. So patients will wear something like a vest. It's a vest that just, they wear on their skin. They don't wear it over the clothes. They wear it so it touches their skin. There could be multiple electrodes, typically maybe 124 or so to 256 electrodes that touch their skin. And then they can non-invasively map these arrhythmias that I was just showing you about. Again, the technology needs to be refined a little bit, but it certainly will be hopefully the mainstay one day too. So non-invasively doing all this stuff, both the mapping and the ablation, is hopefully where we'll end up in due time.
It's amazing. It's a really exciting space to be in. And you shared some pretty cool roles that engineers could pursue within the space, even if they don't go the medical school route. A lot of the attendees on our call today are going to be graduating here in just a couple of months and wanting to pursue some of these opportunities. What advice would you give these candidates?
First and foremost, just honestly, do well in your coursework. It may be too late for some of you if you're about to graduate. What's done is done, but there's learn all you can. And this is true for no matter where you are in your career. Learn all you can. Do well in your coursework. So at least you want to make sure you don't close any doors for yourself. But whether you're still in school or about to graduate, learn as much as you can. Because really the advice I want to give after that is be open to learn new things. A lot of the people, both I remember, I was in academia for many years and I was on, on faculty and I knew people on the clinical side of things and the engineering side of things. A lot of my own professors back in the day, not in med school, I'm talking about in engineering. The older ones or mid-career ones, what they're doing right then and there, that was their area of focus or research or specialty, was very different than what they did for their PhD or what they did in their undergrad. So they learn new skills along the way. They learn new skills, they learn new concepts, they learn new fields. Some of the fields nowadays, like AI, weren't available 10 years ago, at least not the iteration that it is right now. So be open to learning new things and do as much as you can to learn. Be malleable. If there's a field or position that requires you to know something that you may not be as familiar with, you may have some sort of cursory knowledge, read up all you can about it. No employer will expect you to be an expert on that when you're hired. Yes, for sure, for some senior level positions, you very well do need to be an expert. But for the positions for people coming out of college or graduate school, they know that you have limited experience. You're going to learn on the job. You're going to learn on your own too. So keep an open mind, cheesy as it sounds, have a voracious appetite to read and learn and do what you can to learn more technology and learn more everything. Because the times will change. The knowledge you have right now, as high tech as it seems, give it 10 years, give it 5 years at the rate we're going, it's going to be obsolete. So just be prepared to learn new things because as awesome as things are, they're going to get even better in the future. That involves learning more from all of our standpoints.
Great. Just check the chat here. A question did come in about collaborating with people like yourself on the industry side, whether it's in research and development or product development, and just what does that partnership look like? Can you elaborate a little bit on just your partnership with industry in various types of R&D? Maybe it's field clinical support
Yeah.
or development.
No, absolutely. No, great question. I'll speak about it from my end, from the clinician side, because I've never been on it from the sort of industry standpoint, from the industry side. But from my standpoint, it takes a variety of shapes. It could be sort of as simple and easy, if you will. And by that, I mean sort of as a natural part of my day-to-day workflow as using this technology and being willing to try new technology. Going back to what I said before, I have to be open to new technology also. There's stuff that I'm doing nowadays, a lot of what I'm doing that wasn't available when I was in training. So I have to learn new things. And the way I've done that is by, when the companies or the technology is released, it comes from my eagerness and my willingness to try it. So doing that and then giving feedback to the companies, whether it's formally, informally, they're always eager to learn, what can we be done better? What more could this technology do? What are its limitations? Things like that. A little bit more formally, if you do develop a rapport with these companies, or you actively go out and seek out sort of consulting positions, or you answer some company's call, they will really want to know in a more formal environment, whether it's on a contracted basis, you go to their R&D labs, or they come to you, or any which way. A wide spectrum of things. So from sort of the most R&D level, you can go to them with sort of the latest problem that needs to be solved, and then work with them to try to come up with a solution. This marriage is great because the doctors, for the most part, can tell technology companies what the problem is, and then the technology companies can hopefully come up with a solution to it. It's not as cut and dry as that, obviously, but that's one easy way to think about it. So going to them from the very early stages. Along the way, it can come up, you can help with product design. I've done multiple times, gone to sort of their R&D headquarters for various companies that come up with either to help form a device in its infancy, or if they have sort of a prototype available, you sort of test drive it, whether it's in an animal model or in some sort of 3D simulation. You tell the strengths, the weaknesses. You say, oh, no, this is terrible, or oh, no, this is great, or oh, no, this is good, but why don't you refine this? So it comes in many shapes. It comes in many shapes. So from my standpoint, like I said, people usually come to me, but if I go to them, most, med tech companies are more than, all ears to being receptive to input.
That's great. I had one more question get sent in, and this will be a fun one. Dr. Schricker, can you describe a day in the life?
A day in the life for me, sure. I have 2 different days because my day is, I have 2 different types of days. Monday, Wednesday, Friday, sorry. I'm in the EP lab, the electrophysiology lab, doing all that stuff that I was just telling you right then and there with the past couple slides. So doing these procedures. I do about 2 to 5 a day. This is the bulk of what I do, what I just showed you, ablation, but the other set of procedures that I do are the implants, the device implants that, again, Dr. Ricky Green talked to you guys about a couple months ago. So 3 days a week, I'm in the lab. My day starts early, maybe around 8 o'clock, 7:30. The cases can be variable, anywhere from 30 minutes up to maybe 3 hours. The bulk of them take maybe about an hour, hour and a half. Sometimes they take as long as 8 hours. You're there on your feet doing mappings for those VTAC ablations. Those take quite a long time. Sometimes they're shorter. Do them one at a time. That's a full day there. The other sort of the 2 days that I have during my day are I'm in clinic, I'm in office, I'm seeing patients in the office, just as you guys, when you go to a doctor's appointment, what you do, that's what I'm doing just from the other end. I'm providing the clinical care. That's what you do that's what people like myself do to round up cases. You look for people that are referred to you to try to find the cases that you can offer procedures to. So, and that day is, a lot more predictable. It's a lot more, predictable is, the best way to say it. I start typically around maybe 8, somewhere in there, and then see patients in the morning, see patients in the afternoon. And that's really it. So I do this week in, week out. I love the variety. One of the reasons I really love cardiology, the field, and specifically EP, there's so much variety to my not just day, but to my week or whatever, to my career. I do everything from seeing patients in clinic to prescribing medicines that are very specialized that only we people in my field can do, to actually treating patients with my own two hands. There's a lot of immediate gratification doing that. So on an immediate basis, I can help people there again with my own two hands, which is very gratifying. But then sometimes that can become monotonous to just being day in day out doing procedures. So I get the other side of it, which is seeing patients and developing sort of personal relationships with them in the office. So I love that about cardiology. You sort of see patients from start to finish. A lot of it is with technology and diagnostic and therapeutic tools that we do ourselves. We don't send out to another subspecialist. We don't send out necessarily to a radiologist. We diagnose and treat it all ourselves too. So it's a great field, a lot of good variety, and I wouldn't give it up for anything else.
That's amazing. Thank you so very much, Dr. Schricker. I don't think any other questions have come in. Oh, hang on. One just did. Let's see. The question is, what improvements, if any, do you think could be done to complete the mapping for patients with ventricular tachycardia without inducing their VT as often and then resuscitating them? And the secondary question to that is, would there be any way to lessen the risk for the patients?
Yes, doing things to achieve what you were asking would definitely, lessen the risk for the patients. Now, obviously, I may have been a little dramatic with what I said, but it's all very true. But at the same time, we're always keeping patient safety in mind. I mean, again, trite as it may sound, that's always the number one goal. The number one goal isn't to be successful. The number one goal really is to do no harm, is to keep the patient safe. If you can't be successful, that's one thing. If you can't keep the patient safe, that's an absolute no-no in my field. So we're always, that's always in our mind, front and center. But that's a very good question, the ventricular tachycardia, the VT ablations. Yes, there's absolutely a lot that can hopefully be done that we're striving for to be able to pinpoint where that circuit is without inducing their VT. And there's actually, funny you mentioned, a clinical trial that's about to start that we in my organization are going to be involved with this research trial, which is addressing that very thing. This has sort of been something hot that everyone wants to do. How do we know where the circuit is without inducing the VT? And there it goes back to really the cardiac electrophysiology at the, not cellular, but sort of the tissue level. We're measuring signals and we're looking at the signals in just normal rhythm without them being in VT at the time. We're looking at the properties of the signals in normal rhythm to see if that gives us a clue to where that critical isthmus is. And the answer, yes, so far is shown extremely valuable. All the studies so far have shown that it is very accurate and it's a very effective it's a very effective strategy. It's using the same tools that we have already, but just looking at the signals in a very different way, looking at different parts of the signals. So this is something that's very exciting because what we're doing is, without the patient being in that dangerous heart rhythm, we're looking at those signals to see how the abnormality is. Remember, I told you, healthy tissue doesn't have abnormal heart rhythms. I mean, it does sometimes, but the majority of the heart, most of the time, has to be abnormal. What we're looking at is that diseased tissue, where normally we would have gone in carpet bomb, so to speak. We go there and then look at some of the characteristics of their electrical signals in just normal rhythm to see how fast or slow it conducts and look for areas of slowing. And that tells us a lot about where that critical isthmus during the VTAC is. So excellent question. That's something that's front and center in our mind because we don't want to put patients in the VTAC. As much as we can use ECMO to support them, a lot of times we can't, or a lot of times it's just sort of not feasible to do. So again, that's going to the less invasive way of mapping. It's invasive, but at least less risky. So great question.
Wonderful. Okay, one more question. Does the choice between thermal ablation, cryoablation, and pulse-based ablation depend on the type of arrhythmia being treated, or is it more focused on the type of irregularity or tissue you're dealing with?
Great question. The short answer is it depends on the arrhythmia that's being treated. You can use, for the most part, you can use heat or cold, RF or cryo for any arrhythmia. And we've done that for decades. Cryo or RF is a little bit more effective, but cryo very much has a role in certain places because the benefit of cryo is you can do a test freeze. It's not as cold as the test freeze is a little ball of ice that's not quite as cold as the the ultimate burn, the truly therapeutic one. But there you can do a little test freeze to see if you give the full burn or the full cryo lesion, if it causes permanent damage to the heart. So you do this for kids where, you know, their anatomy is very small and you want to see if that area that's in a sensitive spot will cause some permanent damage. You do a little test freeze, and then if it looks like it's safe, then you give the full freeze. If not, if it looks dangerous, then you go elsewhere. So RF and cryo, for the most part, could be done anywhere. The pulse field ablation, that's the new kid on the block. That's the one where at the moment it can only be done for atrial fibrillation. AFib is by far the most common abnormal heart rhythm, the most common arrhythmia in this country and the world. It's rampant. I mean, it's a disease of aging, but we're seeing it in younger and younger people these days. I'm seeing it occasionally in 40-year-olds and even 30-year-olds. So at the moment, pulse field has only been FDA approved, and the catheters are designed just for atrial fibrillation ablation, but very much in the pipeline. I'm talking about within the year. They're going to come up with catheters that look very much like the one I saw. They're point-based. The ones right now we have are more like baskets. They deliver a blast of electric field to a wide area. They're soon going to have these focal catheters like that one that I showed you that can deliver that pulse field energy from a single spot. And then hopefully the goal is to have that be able to replace all the ablation catheters that we have right now. So you can deliver pinpoint accuracy.
That's really exciting.
It's cool stuff. Yeah, it is.
Any more questions before we let Dr. Schricker on his way? You're getting a lot of thank yous and a lot of wonderful presentation. I think
My
this
pleasure.
is really, really exciting for us all. And by far, the prettiest slides that we have seen.
There's definitely a lot of fancy high-tech tools and pretty pictures that we generate.
Yes.
It all goes back to the basics. So again, they're pretty pictures, but it depends on humans. Nothing's ever, well, at least not in the foreseeable future. I think history has shown us wrong a lot. For now, we're not going to be replaced. So there's a lot of role for engineers in this because the pretty pictures are based in humans doing what they're learning in their courses right now.
Wonderful. Well, thank you so very much, Dr. Schricker. We've had one more request. If you would be kind enough to, again, mention your email contact before we let you go.
Let me just put it up on here. Yeah, it's up there. And if you want to just disseminate it after the meeting ends, Jenny, by all means, go ahead. But yeah, you guys are welcome to email me. And thank you so much. This was really exciting. Hopefully I answered your questions. And hopefully I give you guys a glimpse into sort of what my field is and some of the fun things that we do.
It's a very exciting place to be. Thank you so much for everyone for joining. Dr. Schricker, thank you so much for being so generous with your time and your expertise. We really appreciate it. And
thanks so much.
Everyone next month. Take care.
Thanks again. Take care, everyone. Bye.